This is very interesting because, for example, statins are more and more extensively used, and the guidelines say that you should use it on patients with a stroke. And there was not so much about the controversy that an aggressive cholesterol lowering in groups of patients with, for example, cardio-embolic stroke or non-atherosclerotic stroke benefit in the same way as the others that have atherosclerotic stroke and cardiovascular disease. Actually, the three large trials showed a significant number of lowering in stroke events with people taking statins and lowering their LDL cholesterol, but they couldn't really show that these groups have a benefit or a larger benefit of taking it. At the same time, there are side effects of statins, as you know, and it could be shown that there is a higher number of intracerebral bleedings, not in major numbers, but there is, and you should be aware of that. This couldn't be shown in every trial and not in primary prevention trials for example, people that didn't have a stroke or just have the risk profile. But in patients with stroke, there was a significantly higher number in the, for example, in the largest, the Sparkle trial with atorvastatin. There were discussions about why statins could be, for example, responsible for this bleedings, because there is an endothelial dysfunction or frailty. At the same time, the hematoma or the bleeding could be larger in these patients, and there are certain risk groups prone for having more intracerebral bleedings. Other side effects of statins, you might know, is myopathy or pain in the muscles. Dementia has been discussed. Depression has been discussed. And it's more and more also in the market that statins should be used extensively, and even very aggressive lowering has been shown to decrease cardiovascular events. But this is not automatically applicable to all the groups. And there's another group of patients which I want to discuss or focus on, and these are the older women. The benefit has been shown in groups mainly in younger men, men below 75. And there were higher inclusion rates for men because they show more atherosclerotic disease. So the ratio is 40 to 60. And the benefit has not been shown for women over 80, actually. And these women have more cardioembolic stroke than atherosclerotic stroke. And at the same time, it could have been shown that it's a large benefit on cardioembolic stroke or from the heart or atrial fibrillation stroke. Another group of patients is those with lacunar stroke or small vessel disease or advanced vessel disease, and there it couldn't be shown either that they have a larger benefit. But this is on the level that it couldn't be really proved, and there is the evidence in the study. So we need more trials on it. I'm in the controversy. I take the part of the no. So I will show more the downsides and the risk actually than the benefit. The main points that I will be showing it. I will go through the studies, highlighting in the meta-analysis and in the studies and the subgroup analysis that these groups don't have a larger benefit, but maybe a higher risk. And this will be putting the risk to the benefit. And if you compare the risk to the benefit, you could easily come to the point that it is not proven. And the second point I will make is that in observational studies, and this was originally so 3 or 4 studies, it could be shown that patients with a lower LDL or low cholesterol have a higher risk of intracerebral bleeding. So how this connects is not entirely clear, but it couldn't be shown that this is the risk for the higher intracerebral bleeding. But these are the groups, and I will highlight the groups. And the second point is that I will come to the groups which haven't been included in the larger trials and which we can't say anything, and there we have to be cautious. At the end, it won't be that I will say that you shouldn't use statins on this stroke patients, but you should keep in the back of your mind that these have low evidence and a higher risk. And then I will summarize the groups with high risk, or what I thought is a higher risk group for an algorithm or risk score, which I don't have. But these are patients with oral anticoagulation, advanced small vessel disease, older people, women, and people with, where you could say, generally a higher risk for intracerebral bleeding, or with a prior intracerebral bleeding, or people with amyloid angiopathy, or microbleeds on MRI. Like this. So you have to look at these risk groups, and in the future you have to somehow to have your prospective studies to prove this risk in these groups. And then I will show, and this would be also 2 of my last points, that the statin market is constantly increasing, and there is a risk of overuse, which is somehow prone by the general marketing industry, and they might not be interested in financing a trial that is showing that there are some risk groups. And the other point is that all the studies and these studies that are positive are reporting the relative risk, or not the absolute risk. And the relative risk is something that is sounding much more higher than the absolute risk. For example, the relative risk is 20% and the absolute risk is 2%. And this is a recent article also in the Journal of American Medical Association about this topic, that doctors like to look at relative risk reductions. And the industry will also look at it. So these will be my major points.